So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is correct, and after let's discuss this test step by step. So it's 16-year-old boy. He has dark-colored urine and periorbital edema. Dark-colored urine can be caused by increase in bilirubin in the urine or by leakage of massive amount of red blood cells into the urine. Periorbital edema can be caused by either increase in hydrostatic pressure or by decrease in oncotic pressure. From his anamnesis, we know that symptoms started 2 weeks ago after the sore throat, which is basically pharyngitis. He has elevated blood pressure, hypertension in case of 16-year-old boy, most likely caused by increase in hydrostatic pressure. In simple words, fluid overload. He has increased creatinine, and elevated creatinine is a sign of acute kidney injury or muscle injury. Also, he has decreased complement level, which is a sign of formation of complement immune complexes which deposit in tissues. Typically, this occurs in case of disorders with autoimmune mechanism. In his urinalysis, we see mild proteinuria, which means that his urine protein excretion is less than 3.5 grams per day. So we can say that it's definitely not nephrotic syndrome. In addition to this, in his urine, he has red blood cell cast and hematuria. Both of them are the signature features of nephritic syndrome, and it's pretty much all what we have to know. So once again, because this patient has just mild proteinuria, it's not nephrotic syndrome. But he has hematuria and red blood cell cast in the urine, which are the features of nephritic syndrome. Also, he has hypertension and mild proteinuria. So based on this, we can definitely say that he has nephritic syndrome. Before we solve this test, let's explain how glomerulonephritis with nephritic syndrome can explain all his symptoms. First of all, glomerulonephritis with nephritic syndrome causes leakage of red blood cells into the urine. And we know that increase in concentration of red blood cells in the urine can give to urine a dark color. Also, glomerulonephritis caused acute kidney injury, which caused decrease in glomerular filtration rate. With decrease in glomerular filtration rate, the level of creatinine increase, and at the same time the fluid excretion by the kidneys decrease, which leads to fluid retention. And with increase in total fluid volume, hydrostatic pressure in the circulation increase, and increased hydrostatic pressure cause development of hypertension and periorbital edema. So let's solve this test. They ask us about subtypes of glomerulonephritis, and we know that some subtypes are characterized by nephrotic syndrome and some by nephritic. The most crucial thing is to determine the syndrome of glomerulonephritis. In our case, it's nephritic syndrome, which means that we can exclude every subtype of glomerulonephritis which is characterized by nephrotic syndrome. And as we see, -5 possible causes is a substantial help. So we can exclude focal segmental glomerulosclerosis and membranous nephropathy, simply because they cause nephrotic syndrome, and we have patients with nephritic syndrome. The next step is to rule out pathologies within the nephritic group, and in this step we rely on patient's anamnesis and disorders. First of all, we can rule out Goodpasture syndrome. Goodpasture syndrome causes rapidly progressive glomerulonephritis, which also causes hematuria. But in Goodpasture syndrome, patients also classically have hemoptysis, and in our case, hemoptysis is absent, which makes Goodpasture syndrome unlikely. In addition to this, in tests with Goodpasture syndrome, usually we search for antiglomerular basement membrane antibodies, which are a key diagnostic feature. In this case, all of this is absent. So we are left with post-streptococcal glomerulonephritis and with immunoglobulin A nephropathy. And actually, they look very similar. They both occur after respiratory infections as pharyngitis, but the major difference is time of onset. Immunoglobulin A nephropathy occurs simultaneously with respiratory infection, or sooner after respiratory infection. But post-streptococcal glomerulonephritis is characterized by autoimmune reactions, which takes time to develop. Typically, it's 2 to 4 weeks after respiratory infection. In our case, glomerulonephritis developed 2 weeks after pharyngitis, and based on time of appearance, we can say that most likely boy has post-streptococcal glomerulonephritis. Also, decrease in C3 complement level is a characteristic feature of post-streptococcal glomerulonephritis due to the autoimmune mechanism that takes place. In contrast to this, in immunoglobulin A nephropathy, complement level remains normal. So, in tests with nephrotic or nephritic syndrome, anamnesis and disorders which patient has plays crucial role in diagnosis.